Hello and welcome to the webinar. My name is Barbara DiPietro and I'm the Policy Director for the Healthcare for the Homeless Council. I'll be acting as moderator for today's webinar entitled HCH Staffing and Services, National Trends and Implications for Growth. I would like to begin by saying that this is a production of the Council with support from HRSA, the Office of Special Population Health, and this session is being recorded. It's a 1-hour presentation. The last 10 minutes will be reserved for questions and answers. A selected number of questions will be answered at the end of the presentation during the Q&A session. Today's webinar will discuss many different aspects of healthcare for the homeless data, how it's changing, and how it can be used by grantees in planning for the future. We will start by going over the UDS system generally with the changes in reporting in 2012. This will be followed by going over the national trends identified by Council staff in the recently published brief of the same name as this webinar, as well as possible implications and recommendations for grantees to consider. Next, the data collected by the Health Resources and Services Administration's Health Center Patient Survey will be discussed, and finally, representatives from the Columbus Neighborhood Health Center will provide examples of how they use data in their program planning. It's our hope that this webinar will provide a range of options and ideas for local grantees to incorporate data into their decisions and plan for the changes to come in the healthcare system, especially from the Affordable Care Act and other reforms that states are implementing. We have an excellent panel of speakers today. From the Health Resources and Services Administration, we have Heather Ngai and Lydie Lebrun. Each works as policy health analysts in the Office of Quality and Data at the Bureau of Primary Health Care. Heather works mostly with the UDS, and Lydie conducts research using data from the UDS as well as the Health Center Patient Survey. From the Council, we have Dan Rabbitt. Dan is the health policy organizer here at the Council, and he's responsible for policy analysis, federal legislative affairs, and building advocacy capacity throughout the Council's membership. Prior to working at the Council, Dan worked as a mental health counselor and case manager at a permanent supportive housing program for mentally ill adults. From Columbus Neighborhood Health Center, we have Dr. Parminder Bajwa and Dr. Mohari Muhammad. Dr. Bajwa is the Director of Medical Services in Columbus and is responsible for leading and managing all physicians and nurse practitioners, overseeing quality improvement, risk management, and compliance program, and leading the pharmacy program. She brings 18 years of medical experience to include numerous international positions to her work at CNHC, as well as extensive experience in quality improvement. Dr. Muhammad is the Director of Health Center Operations with primary responsibility to oversee daily operations at the 5 health centers. Dr. Muhammad obtained his medical degree in Turkey and is currently enrolled in the Community Health Center Executive Fellowship Program with Kansas University. So with these introductions, I will now pass it on to Heather to get today's webinar started. So Heather, I'll turn it over to you.
Good afternoon. My name is Heather Ngai from the Office of Quality and Data at the Bureau of Primary Health Care. And it's a pleasure for me to join you today to talk about the Uniform Data System. Most of you are familiar with the UDS data, but just briefly, UDS is collected yearly on selected health center characteristics, including demographic, clinical, and financial information. The Bureau and project officers use the data to help monitor your program and work in conjunction with grantees to set and progress toward goals set out in the service area competition and budget period renewal applications. Grantees have the UDS data available to help monitor their own programs and for quality improvement. The purposes of the clinical performance measures. The clinical performance measures help us demonstrate the great value and quality of care health centers provide and allow grantees to have a baseline and set goals for quality improvement in quality of care indicators such as childhood immunization and health outcomes such as diabetes. For the 2012 UDS data collection due February 15, 2013, there's 4 changes I wanted to note. So my presentation is going to be a brief overview of the 2012 changes, but at the end of my talk, I'll provide a link to a much more detailed overview of these changes. Those of you on the phone may have attended the BIPIC-sponsored webinar in April, so this will be a review for you. The first change is Table 5A. This is a new staff tenure table. Table 6A, the second change, an already existing table will record patients and visits by diagnoses regardless of primacy. Table 6B will have 3 new clinical measures, And lastly, there are minor revisions to the EHR questions and a question assessing quality recognition. Table 5A is a new staff tenure table which will allow a better assessment of workforce needs, workforce development, and retention at our health centers. It is based on our current staffing table, Table 5. It will have the same categories as Table 5, but will also collect tenure for certain positions such as the CEO, CMO, CFO, and CIO, the Chief Information Officer. So unlike our current Table 5, which only measures FTEs, this table will measure persons or individuals and will show us, for example, how many physicians work for a health center and for how many months. Currently, our Table 5 shows us FTEs, but we don't know how many individuals encompasses one FTE. The next change refers to Table 6A. The current Table 6A records only primary diagnosis and does not assess the number of multiple diagnoses that health center patients have. In those patients, for instance, with hypertension as their primary diagnosis and diabetes as their secondary diagnosis, currently diabetes is not counted. So in order to address this, in the new Table 6A, diagnosis regardless of primacy will be recorded. So for patients with both hypertension and diabetes, both will be counted. This provides us with a comprehensive picture of all the health conditions experienced by health center patients. The next change will be to Table 6B. There will be 3 new clinical measures added to this table in 2012, and this will help further address the various forms of clinical quality services that health centers provide. The first measure, we're assessing whether patients with coronary artery disease receive lipid-lowering therapy. And our hope is that the likelihood of coronary artery disease-related clinical events will be reduced. This measure is aligned with NQF 74 for those of you who are working on building the criteria into your systems and with electronic health records. In the second measure, we're assessing whether patients with ischemic vascular disease use aspirin therapy. And if so, the hope is that the likelihood of heart attacks or other vascular events will be reduced. Similarly, this measure is aligned with NQF 68. The third measure on Table 6B, introduced in UDS 2012, in this we'll be assessing whether patients in the appropriate age group are screened for colorectal cancers using any of the tests shown here. So that includes colonoscopy, sigmoidoscopy, and fecal occult blood test. Similarly, this measure is aligned with NQF 34. And for those of you, I'm sorry, who aren't familiar, NQF is the National Quality Forum, and our measures are aligned with those from the NQF. 2012 will be the third year of EHR data collection. The Bureau will continue to collect information on health center EHR use. I want to note a minor change to the EHR questions here for 2012. Here's the question shown here. Are providers at your health center meaningful users of HIT? This is the additional question that is being added to the currently existing EHR questions in the UDS. And lastly, a two-part question has been added regarding national or state quality recognition, either accreditation or patient-centered medical home recognition for one or more health center sites. The second part to this question assesses which organization the recognition is from. So whether it's AAHC, JCO, NCQA, or any of the others, simply choose one of those, or you can simply write in the name of another recognition body in letter F. Here's some technical assistance resources I wanted to provide to you. Assistance call that was held in April of 2012, which gives a very detailed overview of what I just reviewed today. That is archived on our UDS website, and the URL is there. Also available on this website is previous years of UDS data. So everything prior to 2012, 2011 will be posted soon, but 2010 and prior is posted on this website at the national and state level for you to access immediately, as well as other reporting and technical assistance tools. So I encourage you to check this website often to get resources. And lastly, I wanted to point out some technical assistance resources again. first is the UDS Help Desk for all content-related questions. For instance, if you're wondering what the universe would be for the colorectal cancer screening measure, or if a certain patient should be counted in the universe for that measure, please refer all those questions to that first phone number and email address listed there. Now, once you're in the system in the electronic handbook, if you have any questions about how to report the data or how to use the EHB, then the BIPIC helpline, that second resource, would be useful for you there. And lastly, there are the program assistance letters. The PALs point out all the changes and things related to UDS and the Bureau that we'd like to note. The first one is approved changes for 2012. That first link goes to PAL 2012-03. That's an updated PAL from last year's PAL. So please use this PAL in referring to all changes to the UDS in 2012, as well as for building your systems to be compatible. And that last link there is to the Bureau website to access any program assistance letter that you might want to access. That is the end of my presentation. I'd like to hand it over to Dan.
Hey, thanks so much, Heather. This is Dan Rabbitt with the National Healthcare for the Homeless Council. I'm going to be basically going over some of the highlights of a policy brief that the Council recently published, entitled the same title as this webinar, HCH Staffing and Services, National Trends and Implications for Growth. So that begs the question, why do we analyze national healthcare for the homeless data? It might be self-explanatory to some, but national data can help in planning and predicting what changes and decisions would be best in the coming years with all the changes coming in the healthcare system nationally. Specifically, health reform, the Affordable Care Act, will require significant changes. The ACA, as it's commonly referred to, has the Medicaid expansion, which is particularly relevant to healthcare for the homeless patients and projects. Most of healthcare for the homeless patients are currently uninsured and are likely to be under the income limit for Medicaid. Delivery system reforms as well, such as patient-centered medical home, accountable care organizations, various other bundled payments and different innovative approaches are all coming, and workforce expansions as well. All these changes represent opportunities for healthcare for the homeless grantees, but also will require planning and thinking ahead about how to maximize these opportunities. And comparing national data to what you're seeing locally can help frame what you're seeing locally and can add to the conversation and thoughts about the changes you're seeing in your community. But why look at healthcare for the homeless data specifically? Well, it's a distinct program. The Healthcare for the Homeless program was started in 1985 through the Robert Wood Johnson Foundation. It was not originally a public program. It was incorporated into the Health Center program in 1996 and is now a Healthcare for the Homeless grantees are now considered health centers, but a special population health center. But there are distinct requirements. Healthcare for the Homeless grantees must provide substance abuse services. They can waive some governance requirements for the 50% consumer board requirement. And I think most importantly, we're charged to serve people experiencing homelessness. So that's going to create differences in the staffing and service patterns in the patient population that we see. One of the first things we looked at was just comparing healthcare for the homeless grantees to all grantees generally. That's what this first slide shows. This is patient income. You see that all the patients at all grantees are disproportionately under the poverty level, but it's dramatically more so for healthcare for the homeless patients. 90%, you see on the slide, are at or below the federal poverty level. And for the Medicaid expansion and under the ACA, if you're at or below 138% of the federal poverty level, you'll be eligible for Medicaid. That's the vast majority of patients seen at healthcare for the homeless programs. This is patient insurance status, also a big difference compared to all grantees in the health center program. 65% are uninsured at HCH programs, whereas only 26% have Medicaid. You compare this to the program overall, and almost 40% have Medicaid already, and 14% have private insurance. This relates to what kind of staffing you're going to be planning for once health reform is implemented and the insurance expansions start rolling out. As a healthcare for the homeless grantee, you'll probably prioritize more on Medicaid and how you get people enrolled in Medicaid and how you advertise and reach out to people to get them enrolled in Medicaid. Health centers, you might pay a little bit more attention to the exchanges. Not more attention than Medicaid, but more attention than a healthcare for the homeless program probably would. So just understanding these differences aids in thinking about strategic planning over the long run. And this is one more slide comparing healthcare for the homeless programs to the program overall. This shows the proportion of visits in 2010. It's important to point out that this is just the proportion. So it's the pie. It's not actually that health non-HCH grantees provide more medical visits per patient or anything like that, but this is just the patient makeup or the staffing and service makeup of all grantees compared to healthcare for the homeless programs. You'll see on the slide that all the program overall is more weighted towards medical and towards physicians, whereas healthcare for the homeless programs provide significantly more enabling services, substance abuse services, mental health services, which isn't surprising because the patients' population seen at healthcare for the homeless programs generally need more support in getting to their appointments and following health advice, and we're mandated to provide substance abuse services. So that's all just differentiating the healthcare for the homeless program from the health center program overall. Next, what we looked at was changes in healthcare for the homeless, staffing and services, and patient makeup over time. This first graph shows the change from 2006 to 2010 in the proportion of visits. Again, this is just a proportion, but it shows that over time, healthcare for the homeless programs provided much more mental health services and somewhat more medical services proportionally to all the services they provided. And it shows that nursing, substance abuse services, and enabling services all went down as a proportion. It's important to point out that the absolute numbers didn't go down for anything because from 2006 to 2010, the healthcare for the homeless program saw over 100,000 new patients, but just the proportion of the services provided went down for those three categories. There's a couple of possible implications of this. It's going to be different from one community to the next, but just a couple ideas that we came up with was, first of all, in looking at how mental health visits increased proportionally and substance abuse visits decreased proportionally, perhaps this is due to an emphasis on mental health, whereas the emphasis on substance abuse has stayed constant. Substance abuse is strong, and the mental health program is just getting better and more robust, so just changing the proportion. It also might represent the integration of mental health, substance abuse services, and primary care. One visit can only be reported as one type under the UDS. So if you're integrating mental health and substance abuse services, it might end up being shown as a mental health visit and not capture the substance abuse content. Or possibly it could be an increased use of mental health screening tools in primary care, which will lead to more referrals and more visits for mental health treatment. Another observation from these graphs that we just went over is the decrease in enabling services. It's just good to point out enabling services are defined as either outreach, patient and community education, interpretation services, transportation, eligibility assistance, or case management. And that could be due to low or non-existent rates of reimbursement for enabling services, insufficient funding for enabling services, or strained capacity and workforce demands where the emphasis on billable visits or stretched workforce might be leading to just a decrease in the proportion of enabling services. Again, it'll be different in every community, but these are just some things to think about. One other aspect we looked at was the change in housing status over time. And this graph shows that over time, since 2006, Healthcare for the Homeless projects are seeing a larger proportion of people who are doubled up meaning living with friends, not being on a lease with friends or family, or transitional housing, whereas the proportion of shelter and street homeless has gone down. This was especially difficult to nail down a particular cause, but we came up with several ideas. And again, it'll be different from community to community, but perhaps it's a proliferation of permanent supportive housing models. That this would be a really positive cause for this change in the patient population at Healthcare for the Homeless. I know in many communities, Boston or Chicago or Denver come to mind, permanent supportive housing has really taken hold and has led to a reduction in the chronically homeless, as well as a reduction in cost. So hopefully we'll see this continue as permanent supportive housing models proliferate. Some other causes, though, could be a general lack of affordable housing in communities, which could lead to more doubled up people who have also the foreclosure crisis. Those could both be causes. Longer shelter stays leading to fewer unique patients. So it's not actually that there's fewer people in the shelters, it's just that the people in the shelters are staying longer. Strained outreach capacity again, or a push for increased number of patients. Those living on the street and in shelters are generally harder to engage than those who are doubled up. And so as capacities are strained, Healthcare for the Homeless projects might not have the resources to go out and spend the time needed to bring in the harder to reach homeless populations. So what does all of this mean? I can't emphasize enough that each community is unique. So please take these just as starting points for discussion. But some broad recommendations that we've drawn from this data include, first of all, engaging in the health reform implementation process in your state. I know some states are not doing much, but most states are engaged in some level, or certainly will probably start to be, depending on what happens with the Supreme Court case this month. Engaging in that process, being a part of the discussion, partnering with your state officials, and making sure that issues of homelessness and health care for homeless people are considered as your state designs insurance exchanges, eligibility and enrollment standards for Medicaid, outreach plans, benefits packages are all very important, and Healthcare for the Homeless staff and clients should be involved in those discussions. Use data to make your decisions about growth, and use data in your discussions about health reform implementation as well. We're presenting a couple sources here. There's lots more data on our website and at various other sources, and local data that you can use through your EHR or other means. Using that data will help the decisions you make about growth and where you want to put your resources that much stronger. Partner with HRSA to grow effectively. Let your the contacts you have at HRSA, be it your project officer or others, know what you're seeing in your community, know how your patient population is changing and how the gaps in services are changing, and that will help strengthen the program. And seek out alternative resources for outreach and enrollment efforts. There are alternative resources out there in terms of public funds, such as the PATH program under SAMHSA or Ryan White program. But these are very diagnosis specific. So seeking out other sources, either through private funds, through HRSA, or through your state Medicaid program, will all help to put in place the outreach programs that we feel are really going to be necessary come 2014 when Medicaid expands, and many homeless individuals may or may not be aware of it or able to navigate the process on their own. So those are our recommendations that we drew from this data. We invite you to draw your own, and any questions you have about it or anything you're seeing in your communities are certainly welcome to be expressed here. But with that, I'm going to pass it over to Lydie to go over some more data that HRSA has collected. Lydie?
Thanks, Dan. And thanks, everyone, for logging in today and listening to this session. Heather and Dan have been spending the session up until this point talking about the UDS data. I'm going to switch gears and spend a few minutes talking about another data source that's housed at the Bureau of Primary Health Care, and that's the Health Center Patient Survey. It's a survey that's conducted periodically, about every 4 to 6 years or so. So it's not done every year like the UDS. But whereas the UDS provides us information from medical records and administrative records, the patient survey gives us information that's reported directly from the patients themselves, and it includes a wide range of topics. The last time the Health Center Patient Survey was conducted was in 2009, and at that time we surveyed over 4,500 patients across the country. We also oversampled patients who attended healthcare for the homeless clinics. So we're able to examine over 600 patients who reported being homeless at the time of the interview. So this is another useful source of data because not only is it nationally representative, but it also allows us to make direct comparisons between patients who are homeless and those who are not homeless, because both of those populations are contained within the same data set. So I'm going to spend a few minutes going over some data points that we've collected comparing health status measures, health behaviors, and healthcare access among patients in health centers who are homeless versus not homeless. So starting with differences in health status, here we're looking at 3 indicators of general health status, and as you can see, all 3 measures show that homeless patients report worse health than patients who are not homeless. At the bottom of the graph, the asterisks just indicate that the differences between the 2 groups are statistically significant. So starting with fair and poor health, over half of homeless patients report that they are in fair or poor health compared to about 1/3 of non-homeless patients. Food insufficiency is defined as reporting that you sometimes or often don't get enough to eat, and about 1/4 of homeless patients report food insufficiency compared to about 10% of non-homeless patients. And finally, for multiple chronic conditions, we looked at a long list of various chronic conditions, including hypertension, diabetes, lung disease, heart disease, liver disease, and kidney disease, a couple others, and we looked at the proportion of patients who reported having 2 or more of those conditions. So 42% of homeless patients have 2 or more versus 33% of non-homeless patients. Turning to substance use, these are 3 measures, again, all indicating that substance use is higher among homeless patients than non-homeless health center patients. About 60% of homeless patients report that they currently smoke versus 30% of non-homeless. Binge drinking is defined as drinking 5 or more drinks on a single day at least 1 time in the past year. So 40% of homeless patients report that they've engaged in binge drinking in the past year, and that's twice as high as the non-homeless patients. The measure looking at high risk for drug dependence is based on scores from the ASSIST scale, and that's a series of questions that ask people about their use of various drugs. And each drug is asked about separately, but we combined all the questions into one measure that looks at high risk for any drug. So 15% of homeless patients are considered at high risk for any drug dependence compared to 1% for the non-homeless population. Then we turn to mental health status. 3 measures again, all indicating higher rates of mental health problems for homeless patients. The psychological distress measure is based on responses to the Kessler scale, which screens for non-specific psychological distress, and it's a series of questions that asks patients how they felt over the past month and adds up the score. So we were looking at the proportion of patients who had at least moderate distress in the past month. So almost 70% of homeless patients report psychological distress recently, compared to about 40% of non-homeless patients. Again, depression and anxiety are a higher prevalence in homeless patients, and those measures are both lifetime measures of depression or anxiety. These are two measures of access to care and dependence on emergency departments. So the left-hand side of the column is unmet medical needs, which is measured as the patient believed that they needed medical care or tests or treatments, or their doctor believed they needed care, and they were either unable to get the care or they were delayed in getting the care. And 43% of homeless patients reported being unable or delayed in getting care they needed versus 29% of non-homeless patients. And we also see much higher reliance on emergency department for homeless patients. So 60% of homeless patients reported that they had visited the ED at least once in the past year. You know, the series of graphs that I just presented, I think it just illustrates on a national level the higher burden of disease that patients who are experiencing homelessness face, and just illustrates the need for ensuring sufficient staffing and services to address their health needs, their healthcare needs, and particularly mental health and behavioral health needs. If anyone has any questions or follow-up after the session, I just wanted to mention that Heather and I can both be reached at this contact number. And with that, I will turn it over to Dr. Bajwa and Dr. Mohammed for their session.
This is Parminder Bajwa from Columbus Neighborhood Health Centers, along with my co-presenter.
Hi, good afternoon. This is Dr. Bahari Mohammed.
Today we are going to introduce you to how we have collected data, and we have moved up in our measures, in our QI measures internally, as well as while reporting our UDS reports. I want to start with the mission. I want to introduce everybody to the mission of our company. That's on our first slide. Is to serve the community through services that improve the health of families, including people experiencing financial, social, or cultural barriers to health care. And and this is another piece of small information we have. Last year we received level 3 recognition for from NCQA for our patient-centered medical home project. We got level 3 for all our 5 centers in our first attempt, which was a big thing for us, and it came as a surprise. We didn't know that we were using data so much that we had improved in last 4 years. I'm going to hand over to Dr. Buhari from here to talk about our internal CNHC clinical sites and structure.
Good afternoon again. Columbus Neighborhood Health Center, last year, 2011 data, we have up to 96,000 encounters throughout the year and 26,000 established patients, all coming from this location of clinic. We are 330E and 330H, which is we have the homeless program, including the other non-homeless program. And the structure here shows our 5 clinics, East Central Health Center, Westside Health Center, John R. Maloney Center, St. Stephen's, and Columbus Northeast Health Center. But we have a satellite clinic, which is at Faith Mission for the homeless population, that we do intake. When we intake the homeless population, they are all established into the regular clinic that we have. So the data we're going to show you that we sent to UDS and we have here is actually all population. So we don't segregate our homeless population from our QI initiative. So they are all inclusive here. So this is the structure of CNAC. In the next slide, we're going to show you the demographic of the patient population. Here you can see that our homeless population are 6.56%. And then the normal population, which are non-homeless, 79%. So this is the background of the information that we're going to be talking about based on our QI measurements.
Here we have our QI program goals. In 2009, we revised our QI plan, and we came up with a very robust QI plan with 22 indicators. From 2010 onwards, we started reporting on 16 to 17 of those indicators. We have a quarterly report, which we do very religiously, which comes right on the time every quarter after every 3 months. Then we have our annual report, which we try to make it in the first month, in the last week of January. So each year from 2010 onwards, we have been on the data as it shows. So when we see any fall, any dip in the data, we immediately go back and contact our nursing staff who call the patients and get those patients, for example, if we're talking about immunization, call those patients and get the immunization done. So to overall lead that, we have a very dedicated team who leads this. It is extremely to demonstrate excellence. We look at the data and look at it again. We follow this sentence every quarter. We identify the gaps. We measure our performances every quarter. The next important thing what we have been doing religiously for last 3 years is we share the data with each staff member of CNHC. It starts from the board and it goes to the front desk. Every member of CNHC, they are familiar with the data quarterly as well as annual report. Our quarterly data is shared every quarter by our QI coordinator, who goes to the centers and presents it at their staff meeting. So people are seeing the numbers, and they are, when there is a dip, so they get worried, and when they see the numbers are growing up, so they celebrate. We are very critical of ourselves. We try always to go back and look what happened, why we missed it. We are very good in identifying our missed opportunities, and we work on it. There is always an area of improvement, and we bank on that. We follow up on our missed opportunities immediately after each quarter report. It is very important, and we do it especially for immunizations, pediatric and adult both, and also for abnormal PAPs. And here on this slide, we have, sorry, I apologize, it's kind of clumped up together, but that's how we wanted to present it to you all, to see how we have this range which varies. The blue one is our target. The next is dark red in color, which is 2009, and then is 2000, similar, it's orange in color is 2010, and blue is 2011. I will talk about the pediatric immunizations. Let's do that. So if we see from here, 2009, we were at 55, and we went up to 82 in 2010. The dip in 2011 is about those two immunizations which were added up, and that is kind of our fault. We did not go back and check, so that's how we identified it, and so let's see how 2012 data comes up. And we see we pick up another one. Let's talk about abnormal PAP. So in 2009, we did not have any
tracking for abnormal PAP. We did not measure it, but we still had the target which we had built in our QI plan according to the clinical indicators. I couldn't have gone beyond finalizing the QI plan without abnormal PAP being there. So we built the target for 95%, and the first year when we measured it was 2010. We found we were doing very good on that, and we were at 97%. So we are still doing very well on it. It's following each patient, and so we are still at 2000. In 2011, we are at 97%. Geriatric immunizations. This was very interesting. In 2009, we measured it, and I could not believe my eyes. We were at 5%. So for the whole year, we worked very hard, and with our patients, we came across loads and loads of obstacles, the compliance, and because of course we have patients with limited resources, we still got a percentage up to 39%. And still we were working hard, and here we are at 59%. I'm very happy with that. So similarly, if we talk about hypertension, though there is a small growth, but it's still growing. So this is, I just wanted to share our internal processes, how we work constantly, being critical about ourselves. We look at the numbers, we go back into the clinics, check. Our nurses are great in following with the patients, and our QI coordinator is also doing great on it in managing and monitoring that. Here this is kind of a slide which is preaching. When we do it, I wanted all the staff members to understand why we are doing this. So the importance of data, which I thought that if we do not have the medical assistants, the nurses, and the physicians, nurse practitioners understand that what is the importance of data, we will never grow up in our numbers, in our percentages. So we started educating our providers, our nurses, on why do we want to do this? What is the reasons of doing this? So we followed the same plan, do, act, solve and act model. The focus was on the process, not the outcome. So we started cleaning our processes, building our processes stronger, leaner, without any flaws. So that was a first. And if the processes measures are 100%, the outcome measures, ultimately, they were better. So, and we believe in we don't report just to meet the requirements. We are doing it because that is what we should be doing as a right thing. Dr. Bahari Muhammad and I, we are open for questions. And from now, I will hand on to Barbara. Thank you so much.
Thank you, and thank you all the presenters. I think that was a really interesting way of being able to look at a variety of different ways of looking at data to achieve the goals that we're looking to, whether it's in quality or staffing or services, particularly where we are now with our patients, and then where we're looking to go in the next, particularly the next couple of years. At this point, I want to open it up to some questions. I see one is a logistics question about getting access to the slides. The slides and this recording, all of this will be available on our website within 72 hours. And I believe that at the close of this presentation, you will get an email with an evaluation that will be filled out, and then that should also direct you to where you can find this information on our website. A couple of questions I know, I'll just wait and see if we get some more posted from our participants on this webinar. But in particular, I know that we've been talking with folks, And we have actually a group of people here who were looking in and have asked us some questions here. And so one of the things that I wanted to pass on, and I think this is a question for Dan, in responding to the graphs that you had put together showing the difference between HCH and regular grantees and the trends over time, someone had asked that the trends in their community are very different. And so what should you do with the data when the trends nationally differ so starkly from what you're seeing locally?
Well, yeah, thanks, Barbara. I think certainly it's just a starting point for discussion, the national trends. What is most important for your local project is your local data and what you're seeing. I think maybe it can bring up some questions. For instance, if you're seeing an increase in enabling services or something of that sort, whereas nationally we're seeing a decrease, asking what are you doing differently, perhaps doing, maybe even doing better, and how can you share that with us would be interesting. And there's always a story behind the data. So figuring out how that connects to what you're seeing is very important. These national trends are just a starting point. It helps to think about the program overall, but each individual community is going to be different. So thanks.
Thank you. Next couple of questions that, again, we had gotten here on our end that I don't see being entered in formally are probably better for our colleagues from HRSA. In particular, why does the ACA impact staffing and services? And I didn't know if Heather or Lydie, you wanted to address that question. You can also refer it to someone else.
Thanks for your question. I don't think we have a good explanation for why the ACA would impact that, but what we can do is take that back to other colleagues in our office and then send the response back to you.
That's fine. And I think just in the work that I've been doing, I can probably take a stab to it. It's just offering a little of perspective. I think in particular Dan had opened by talking about the health reform and the Medicaid expansion. I think one of the things that we might anticipate, particularly given we have disproportionate levels of those who are uninsured who will become Medicaid eligible, I think that increase in demand for services, I think that as we're looking at the maybe some changing demographics of our patients as people come to health centers in general, but also to HCH, on how does that change the behavioral health needs that we're seeing? Do we see that pent-up demand in our patients that we see that it's in the general public to begin with? And so I could see certainly the increase in demand for primary care providers and behavioral health, and for the kinds of enabling services that Dan described earlier. Is will more patients mean more need for transportation, more need for interpretation, the outreach, and the other assistance? So I think that there are a lot of things that we might be able to look at.
And Barbara, if I may, I think another big thing is just, I didn't mention this in the presentation, but just a change in billing. If you're able to bill for specialty care, you're able to bill for mental health services, and just your revenue makeup at your project is going to change dramatically, then that will probably influence the sorts of staffing and services that you can have under your roof and you can seek out.
True. Yeah.
So I think that's another way that it might change the decisions you might make otherwise.
Thank you, Dan. I see we've got a question here from Mickey. Given the extremely high rates of brain injury in the homeless population, especially among people who are homeless long-term, and the necessity of nationwide screening for this public health disaster, why am I not seeing data related to brain injury? Did Lydie or Heather, did you want to take that from HRSA? This might be a question that's related to what kinds of data that UDS collects.
Well, currently brain injury isn't being collected in the UDS, but yearly on a yearly basis, we do review different types of services as well as diagnoses that we might want to add to the tables. So it could be something that we consider in the future.
And then from the patient survey perspective, I mean, something to keep in mind is that it's meant to be a survey that represents all health center patients, not just homeless patients. So typically we've focused on conditions that tend to have higher prevalence rates, and brain injury, even though there's higher rates among homeless patients, might not be that high generally across, the entire health center patient population in general. But that's not to say that, it wouldn't be possible to add an additional question. We ask about a whole slew of chronic conditions and injuries and so on, so we could potentially add a question about brain injury for the next round.
Thank you. I appreciate that perspective. Another question that we've gotten, again, not seeing it entered here, but we're getting it from some of the folks viewing here, is how can HCH grantees staff properly to address the disparities that are shown in the health center patient survey? And so this is a staffing question at HCH related to disparities in the information that that Lydie had presented. Lydie, do you feel comfortable answering that?
Well, I think that the data that I showed just illustrates, the higher burden of specific conditions, and I, focused on mental health and some behavioral health measures. So, to the extent that that's more prevalent among homeless patients, I think we could make the case that higher staffing rates are needed to be able to address those issues. And I think that Dan also presented some data from the UDS that illustrates that that's already going on, but it may be that it needs to be even more.
Thank you. Next question is for our friends in Columbus Neighborhood Health Center. Looking particularly at the QI information that you had presented, and curious about how that might have impacted your decisions on staffing and how you organized or arranged your services. Dr. Bajwa or Dr. Mohammed, do you have any thoughts about that?
Hi, I'm Parminder. So the first thing, when we looked at our internal structure, so we wanted a QI coordinator. At that time, I was in that position. So, being a physician and in that position, it helped me a lot to take the load and take the decisions and lead the nursing crew in such a way so that they could understand what I was asking for. And when we did this for, I think, about a few months, 4 or 5 months, they understood the importance, and there was a steep growth in that understanding. And there was also interest in going back and following what I mentioned about the QI indicators. So from then, we made lead nurses as the point person in the centers to follow on those patients. As I moved into a different position, this was taken up by our present QI coordinator. So she started educating she's a physician too, so she started coordinating that on the same grounds. We also constantly have worked as a team with our director for operations, and he's a physician, and I think I'll hand over to him, so how he took that role. So here's Dr. Buhari Muhammad.
Right. So if you want to look at staffing, I think throughout this experience, there's no perfect staffing model for any program. But what we've tried to do over here is to build in the program in the system. So when we are even losing staffing, anybody who is coming in here knows that QI program is part of CNAC. So it's building the program in part of the as a job description. So it's not dependent on one person or one physician or one nurse. It is part of job description that is required by the staffing here. So that's the summary explanation I can give about getting the staffing to do this. So it's part of the system. So when people move on, people that come actually also work the same thing.
Thank you. Appreciate that perspective. We've got another question here. How is How is this going to affect the reality of new and expanded clinics and access points without supporting staffing and services funds? Lydie or Heather, do you feel comfortable answering that from HRSA's perspective?
We are really mindful of the constraints that are put on grantees and those applying for funds. And so we rather work with you as much as possible. So in that process of applying for new access points, service area competitions, we do encourage you to work with us directly and talk with us and see how we can assist you. But we are aware of the different types of constraints that are put upon the grantees and those seeking funding.
Thank you. At this point, I'm not seeing any additional questions. I want to show that there is more information at the Council's website. We offer extensive TA and training. We also do research and education, particularly around the Affordable Care Act and how some of these changes are going to be impacting healthcare for the homeless grantees. You can also get a free individual membership at the link that's here. And again, I would encourage you to check out the policy brief on this website under Policy and Advocacy, under Council Materials, that has been published that really goes more in depth to some of the graphs that Dan had walked through earlier and some of the implications. In particular, some recommendations on things to be thinking about as you use data, a wide variety of data to include the UDS, but also your own internal measures like the folks in Columbus are doing. Really appreciate everyone who attended this webinar today, and with that, I will close the webinar.